I'm very grateful to Monica Cruz and the other organizers of this meeting for giving me the opportunity to talk on prediction and prevention of preeclampsia in your Euro-American Congress in Fetal Medicine. Prediction and prevention of preeclampsia has a long history, and I will present some of our latest results and their relevance to a new approach to clinical management. In England and in many other countries, the method of identifying women at high risk for preeclampsia is based on a series of factors from the mother's history. For example, here, when we first see a woman in the beginning of the pregnancy, we need to ask her 10 questions. And if the answer to the first 5 questions is yes, then they are considered to be at high risk. And if we also have a yes to 2 of the remaining 5 questions, then they're also considered to be at high risk. The first 5 questions are whether a woman had a previous history of preeclampsia, whether she suffers from chronic renal disease or chronic hypertension, diabetes mellitus or lupus or antiphospholipid syndrome. The other 5 questions are whether this is the first pregnancy, whether she's more than 40 years old and has a high body mass index of more than 35, whether the interval between this and the previous pregnancy is more than 10 years, and whether her mother or her sister had developed preeclampsia. This is what we do. This is what they do in the United States and in many other countries. But until now, we don't really know how good is this method of screening. What is the screen positive rate? What is the detection rate? The approach that we have used in the last 20 years in screening is to use Bayes' theorem and calculate the individual patient risk. We start off, for example, in screening for Down syndrome, from the background risk, the prior risk, the maternal age-related risk, and we modify this by taking into account the measurements of nuchal translucency, free beta HCG, and PABA. We use the same approach in screening for preeclampsia. We use all of the maternal factors that are known to be associated with increased risk. We'll do a multiple regression analysis, which allows us to define the importance of different risks rather than considering them all the same, and the interrelationship between the different risk factors. And that defines the prior risk, the starting risk. We then measure a series of biomarkers, and over the years we identified 3 important biomarkers, and these are mean arterial pressure, uterine artery pulsability index, and maternal serum placental growth factor. We modify the prior risk using these biomarkers to define the posterior individual patient risk. And then we decide which is the cutoff point we want to use and what is the detection rate, the screen positive rate that is equivalent to that. But unlike Down syndrome, where you either have Downs or you don't, in the case of preeclampsia, it is important to incorporate in the mathematical model the gestational age at which somebody develops or delivers with preeclampsia. There's a completely different preeclampsia that causes delivery at 28 weeks rather than preeclampsia that appears at 42 weeks. So with our mathematical model, we allow the calculation of risk for any gestation that somebody wants to define as the cutoff. And over a number of years, we have been using this method and evolving the development of the method. And in 2016, we published in the American Journal of Obstetrics and Gynecology a study involving nearly 36,000 pregnancies at 11 to 13 weeks, where we combined the information from the history together with the measurement of the mean arterial pressure, the uterine artery pulsatility index, and using automated machines with reproducible results, maternal serum placental growth factor. And we found that with this method, at a false positive rate of 10%, we could identify about 90% of the women that we deliver with preeclampsia before 34 weeks, 75 with preeclampsia before 37 weeks, and about 45 with preeclampsia at term. Once we developed the method and we presented the first results, of course, the question was, can this model apply in a different population? So we needed to validate the model. And to do so, we went to a series of hospitals in Spain, Murcia, Granada, Tenerife, in Belgium, Brussels, in Italy, Milan, in Athens, in Greece, and 6 government hospitals in England. And we examined nearly 9,000 women. The black lines are the predictions, and the red lines are the observed detection rates. And you can see that more or less in this prospective screening study, again, the detection of preeclampsia before 34 weeks was about 90%. Before 37, it was about 75%. And at term, it was about 45%. More recently, the British government gave us a grant to compare the method of screening that we were proposing with that based on the history, the NICE guidelines. We took 7 hospitals. We did screening at 11 to 13 weeks. We did not intervene. We did not take the results of the screening into account. We examined 16,700 women, and we compared the NICE method based on factors from the maternal history and the Fetal Medicine Foundation algorithm. All of the results were kept secret by an independent clinical trials unit at University College in London. And these are the results. In screening by the NICE guidelines, the screen positive rate was about 10%, and the detection rate was 47% for preeclampsia before 34 weeks, whereas with our method, it was 90%. It was 41% for preeclampsia before 37 weeks, and with our method, it was 82%. It was 26% for term preeclampsia, and our method showed a detection of 44%. So it is now clear that a method which combines history with biomarkers is by far better than a method that relies on history alone. We then took the results from 61,000 pregnancies that we examined in the first semester, and again, using the method that we proposed of a combination of history with mean arterial pressure, uterine artery pulsatility index, and placental growth factor, provided a detection of preterm preeclampsia before 37 weeks of 90% before 32 weeks and 75% before 37 weeks. Now, it is clear that this is the best method of screening, but there are different elements that we need to take into consideration when we are thinking of clinical application. So we have to take a history, and we need to record the information accurately. We need to measure the mean arterial pressure, but we need to do so accurately. We need to use an automated device. We need to get the woman to rest for 2 or 3 minutes, and then we must support her arms at the level of the heart, and we must use the right cuff for both arms. And after 1 minute, we take another measurement, and then we join up the results of the 2 measurements from the left arm and the 2 measurements from the right arm, take the average mean arterial pressure. It is not a straightforward approach. It's easy, but doctors are impatient, and it may be better to have a nurse that is properly trained to take the measurements if we want to get reliable measurements. Then we need to measure the uterine artery pulsability index, and we need to learn the technique, we need to train, and we need to audit our results to see that we are getting the right measurements. And then, of course, we need to measure the placental growth factor, and it is important to use the reagents and the machines that give reproducible measurements. But again, we need to audit the results. Once you take these measurements, we need to take into account the fact that they are dependent on a series of maternal factors, and we need to convert them by correcting for these factors into multiples of the median. The values change with gestation, the values change with maternal weight, with smoking. They depend on whether you're black or white, whether you conceived by in vitro fertilization or not. And therefore, before we can compare the results from different studies or different people, we need to correct for these factors that affect the measurements. And then we need to define what is preeclampsia. Unfortunately, there are many definitions of preeclampsia, and it is important that people use a standardized definition, and that we take into account whether a woman in our study is taking aspirin or not. As you will see in the rest of my lecture, aspirin dramatically reduces the risk of preeclampsia, and therefore if you're doing a study and many patients that are at high risk are taking aspirin, then your performance of screening will appear to be low because we are eliminating preeclampsia. There are a lot less cases of preeclampsia. We identify somebody as being at high risk, but because they're taking aspirin, they do not develop preeclampsia, and therefore we classify them as being a false positive, which is wrong. And then we need to take into account the fact that the performance of screening will vary with the study population. Because if you have a population in one country which has a high risk of preeclampsia, and in another country where there is a low risk in preeclampsia, then when you use a certain cutoff of risk to define the detection of the false positive rate, we will get different results. But I will explain this a little bit later. This slide is to show that in England, there's a national government-driven program of audit of results in screening for Down syndrome, for example. And we have to have the same method in screening for preeclampsia. You take the mean arterial pressure, you convert the measurements into multiples of the median, and then we know that the results must be in the green band. If they're in the yellow band, they are a little bit uncertain, the results, and therefore corrections need to be made. And if they're in the red band, then something wrong is happening. And the same is true with the uterine artery pulsability index and the placental growth factor. And these are the results from individual centers. You can see that in many centers, for example, they were not using the right assay, or they were not making the right adjustments, or the formulas for making adjustments did not apply to that population. The results are based on our research in our center, in our population, and adjustments need to be made for different types of populations. Let me explain the concept of a risk and screening performance based on different populations. We know from 25 years ago that the best way of screening for Down syndrome is the first trimester combined test, which combines maternal age, nuchal translucency, pre-beta HCG, and PABA. And we know that if you use a risk cutoff of 1 in 250, the screen positive rate is about 5%, and the detection rate is about 90%. Cutoff 1 in 250. In England, the government introduced a method of screening based on the combined test, and they say you are screened positive if your risk is more than 1 in 100. But if we lower, if we change the risk from 1 in 250 to 1 in 100, the consequence of that is that the screen positive rate is reduced to 2.7%, and also the detection rate is reduced to 86%. So the first lesson is that when we discuss performance of screening, screen positive detection rate, we need to define what is the risk cutoff that we are using to define the high-risk group. The next thing is shown here, and this is very dramatic. Although in the total population, the performance of screening is 86 for a screen positive rate of 2.7%, in individual women, the risk is different based on their age. So for women that are about 20 years old, with a cutoff of 1 in 100, the screen positive rate is only 1%, and the detection rate is 70%. Whereas for women that are about 45 years old, the screen positive rate is 33%, and the detection rate is 97%. So you cannot say that the results are the same for everybody. If you have a population that is predominantly young, the detection and screen positive rate will be different than if you have a population that is predominantly old. This is in screening for Down syndrome. And of course, we found the same in screening for preeclampsia. For example, Black women have a much higher risk, 3 times higher risk of developing preeclampsia than white women. So when we screen a total population, we say the detection rate is 75% for a positive rate of 10. But actually, if we take a cutoff of 1 in 70, in white women, because they have a lower risk overall, the screen positive rate is only 7%, but the detection rate is only 65%. Whereas if we use the same method, the same cutoff, in Black women, there's a much higher screen positive rate, much higher background risk, and a much higher detection rate. Another important question that is being asked is, do we need to do mean arterial pressure, uterine artery pulsatility index, and placental growth factor in all the patients? In some centers, they can do the uterine artery Doppler because they have good ultrasound facilities. In other centers, they can buy a PLGF and do mean arterial pressure and PLGF without doing the uterine artery pulsatility index. What happens then? Well, we have learned that if you do screening in all of the women with the 3 tests, MAP, UTPI, and PLGF, and you use a risk cutoff of 1 in 70, in our population, the screen positive rate is 10%. 90% of women are screen negative. And this group of 10% contains 75% of the women that will develop preterm preeclampsia. The other 25% are in the screen-negative group. This is when we do all of the tests in all of the women. Can we select women where we do only some of the tests? This is called contingent screening. And this shows what we predict would happen. If you don't have good facilities for measuring the uterine artery perceptibility index and you do screening by history, mean arterial pressure and PLGF, or if you have good facilities for Doppler, but you don't have money to measure the PLGF, you can screen the whole population using one of these two methods. And then we use a risk cutoff now, not 1 in 70, but 1 in 2. And you classify women into screen negative, positive. 30% of women in the screen negative group and 30% in the screen positive group. So that we then only in this 30% of women we can do the uterine artery or the PLGF. And then we second stage screening. Again, we classify women into screen positive, screen negative, and screen positive with a risk cutoff of 1 in 70. We achieve the same performance of screening, overall detection of 75%, overall screen positive rate of 10%. But now we achieve that with needing to do PLGF or uterine in only 30% of the population. This is prediction of preeclampsia. I will now be discussing prevention of preterm preeclampsia. Many methods have been tried in the last 50 years, bed rest and various dietary manipulations, and the randomized studies, the good research has shown that none of these methods is useful. It is not useful to put women in bed, to restrict their physical activity, to restrict the salt intake, or to supplement the diet with magnesium, zinc, folate, vitamins C and D, or fish oil. What is known to be useful is that in countries with low dietary calcium, if you give calcium supplementation, then we reduce the risk of preeclampsia by about 50%. So low calcium intake countries, calcium reduces the risk of preeclampsia. And now the story of aspirin. In 1985, we saw a publication in the Lancet from France. They took 102 women that were at very high risk of preeclampsia and fetal growth restriction. They gave 150 milligrams of aspirin starting from 12 weeks. 150 starting from 12 weeks. And they compared the results with a group of women that did not receive any treatment. And they showed that in the no treatment group, very many women developed severe preeclampsia, fetal death, or fetal growth restriction, whereas in the group that received aspirin, 150 milligrams from 12 weeks, there were no cases of these complications. And you would have thought that in 1985, with these results, by now, so many years later, it's more than 30 years later, we would not be presenting a lecture on aspirin and preeclampsia. We would not be discussing anymore this issue. But unfortunately, something went wrong after this study. And what went wrong is that many people received a lot of money from the governments to do new randomized studies. But it is very tragic that in these new studies, they were using not the recommended 150 milligrams, but 40 or 60 or 70 or 80, much lower doses of aspirin. They were also not starting at 12 weeks, they were starting at any point, 20 weeks, 30 weeks, 32 weeks. And they did not have one definition of preeclampsia, they had 14 different definitions. So all of this data was collected, and we were in the era of meta-analysis where somebody takes these results, different studies, different populations, different doses of aspirin, different starting points for treatment, different definitions of preeclampsia. They mixed them up all together, and they arrived at the conclusion that aspirin is not very useful. Maybe it reduces the rate of preeclampsia by 10%, and that's all. And it doesn't matter what you take, when you take it. And that is why different people in the world do different things. This is what I call the 30 wasted years. We therefore have to repeat what was done in 1985. But this time, we used our method of identifying the high-risk group. We took 26,900 women, we screened them, we identified the high-risk group, and then we randomized the high-risk group into aspirin or placebo. And in the aspirin group, we gave 150 milligrams of aspirin starting from 12 to 36 weeks. And we published these results in the New England Journal of Medicine last year, and we showed that with this dose of aspirin, we reduced the rate of preeclampsia before 32 weeks by about 90%, preeclampsia before 34 weeks by about 80%, preeclampsia before 37 weeks by about 60%, and there was no effect on term preeclampsia. We then did a number of secondary analyses, and we showed that the overall reduction of preterm preeclampsia was 62%. But if we look at the subgroup of women that were taking their medication, they had a good compliance of more than 90%, then the reduction was 76%. It is absolutely certain that if you're given a drug and you don't take it, it doesn't work. So if we look at good compliance, we have a 76% reduction in the rate of preterm preeclampsia. We then looked at another question. Does it matter what was the reason that made you high risk? Or does it matter if you have a woman that is young or old, has a low or a high BMI, if she's black or white, she smokes, she has a family history, or her previous obstetric history, or chronic hypertension? One is the no effect. Here is the 62% reduction. You can see that more or less the results were the same, except for chronic hypertension, where, although the numbers are small, it appears that aspirin is not useful. So if we ask the question now, we have a woman at high risk at 12 weeks. She does not have chronic hypertension, and she has a good compliance. We could potentially reduce the rate of preterm preeclampsia by 95%. We then looked at the literature, and we did a meta-analysis using the same criteria. And we confirmed that aspirin does not have an effect on term preeclampsia, but it has a good reduction of risk of preterm preeclampsia. So aspirin is not good for term preeclampsia, it's only good for preterm preeclampsia. And then we asked the question of, does it matter how much aspirin you take, and does it matter where you start your treatment? And the answer was very simple. If you start aspirin before 16 weeks and the dose is more than 100 milligrams, then we have a dramatic reduction in risk. But if you take aspirin after 16 weeks, there's no effect, irrespective of whether you take less than 100 or more than 100 milligrams. And also, there is no significant effect if you start before 16 weeks, but the dose is less than 100 milligrams. We also asked the question that many people are afraid of. can aspirin increase the risk of abruption? And the answer was very clear. If you take less than 100 milligrams, either before or after 16 weeks, it doesn't matter because it doesn't affect preeclampsia anyway. However, if you take more than 100 milligrams and you start before 16 weeks, you reduce the risk of abruption, whereas if you start for the first time after 16 weeks, you increase the risk of abruption. The final part of the lecture is, but is this method cost effective? Is it worthwhile? Should we be giving aspirin to everybody? Should we continue to screen? And the answer is very simple, really. In medicine, one of the biggest problems that we have is lack of compliance. It is impossible that women will all be told, take aspirin, and they will take it. They will not. They don't even take folic acid, even if we know that folic acid reduces the risk of spina bifida. Women don't like taking drugs in pregnancy. I believe that it is much more likely that they will take the medication if they're identified as being at high risk. And also, we say that aspirin is safe, but in reality, even if there's a very, very small increase in risk of hemorrhagic events, because the rate of preterm preeclampsia is very low, it's about 0.7, 0.6, 0.8%. We need to treat a lot of women with aspirin, and if it has a very, very small risk of hemorrhagic events, then maybe the benefit of reducing preeclampsia will be outweighed by the risks from taking aspirin in everybody. That's why I believe that we should do screening, and it is worthwhile doing screening to identify the high-risk group. But is it effective? Is it cost-effective? Well, in the aspirin study, we found something dramatic. In the women that were taking aspirin, the length of stay in the neonatal unit was reduced by 68%. And in obstetrics, the biggest cost in care relates to babies that are very, very small, before 32 weeks, and the length of stay in the neonatal unit. In England, every day that you stay in the neonatal unit is more than £1,000. In the United States, on average, is about $2,000 per day. When we take this reduction from screening and treatment with aspirin, then the amount of money that is saved is so dramatic that it can easily be used to apply and pay for screening in the whole population and still have a major saving in cost. There's something more than that. We're talking about stay in the neonatal intensive care unit. But if we look at these children 1 to 5, 20 years later, then we learn something very important. If we look at children at the age of 2 years, from a study now in France, in the neonatal unit, babies that were born before 32 weeks, and they survive at the age of 2 years, but we follow them up at the age of 2 years, then the number of babies that will die or survive with handicap is 20%, whereas those that are born after 32 weeks is 2%. So very premature birth, which is actually prevented by aspirin, and very early preeclampsia is reduced dramatically. We will not only reduce the length of stay in the neonatal unit, but also the risk of handicap and death by the age of 2 years. And then there's another study from Norway, published in the New England Journal of Medicine, that looked at people at the age of 20 and 30. And again, you can see from here that the earlier you're born, the greater is the risk that you will die by the age of 5, or you will develop cerebral palsy, or even at the age of 20 and 30, you will be unable to have a job. So prevention of severe early onset preeclampsia, reduces length of stay, and it is likely to reduce death and handicap in the whole life of an individual. So to summarize, if I take the results from the ASPRED study and the meta-analysis that we carried out, we can conclude that aspirin should be at least 100 milligrams, and the onset should be before 16 weeks. And if we do so, we are reducing the risk of preeclampsia by 90%, preeclampsia before 34 weeks by 80%, preeclampsia before 37 weeks by 65%. We reduce the risk of abortion, and we dramatically reduce the length of stay in the neonatal intensive care unit. So it is very obvious that with these results, everywhere in the world, we will immediately adopt screening and prevention of preeclampsia. Is that true, or nothing will happen? Well, to answer this question, we need to look at the history of medicine. And I take as a simple example what happened in screening for Down syndrome. In the 1980s, in many countries, they were performing screening with the double, triple, quadruple test in the second trimester, where they were using maternal blood taken at 16 weeks, measuring alpha-fetoprotein, HCG, estriol, and inhibin to define the high-risk group that would benefit from amniocentesis. The performance of screening of this method was 60 to 70% detection at a false positive rate of 5%. Then, in the early 90s, I introduced another method. In the first trimester, we could combine maternal age with nuclear translucency, free beta HCG, and PABA, and now the detection rate was dramatically increased to 90% at the same false positive rate of 5. So, by 1998, we published a paper in The Lancet involving 100,000 women, showing that this method is much more effective than what we had with the serum biochemistry. What do you think happened? This was in 1998. The National Screening Committee in 2002, 4 years later, this is the government body that defines screening for the country, came up with a statement that women should be offered second trimester serum biochemistry with a detection rate of about 60%, and that the first trimester screening is not yet ready to be introduced. We have to continue to keep it under review. And at that time, I was very, very angry. And I said, contrary to what I thought when I was a little child, that dinosaurs were extinct, it is not true. There are many dinosaurs within governments. There are many dinosaurs within the medical profession that prevent progress to be made for the benefit of pregnant women. Fortunately, women screamed and they demanded the first trimester combined test, and 6 years later, or 16 wasted years from 1992, the government was forced to introduce first trimester screening for the whole country. Now, this lesson tells me that it is unrealistic to believe that the first trimester combined test will be introduced for screening for preeclampsia. Indeed, I was very angry when last week I read that the American College of Obstetricians and Gynecologists and the Society for Maternal Fetal Medicine of the United States, the self-proclaimed high-risk pregnancy experts, after all of this evidence, all of these papers I deliberately published in the New England Journal, in the American Journal of Obstetrics and Gynecology, and this month they come up with a statement, July 2018, The dose of aspirin should be 81 milligrams. The onset of therapy should be any time from 12 to 28 weeks. And the method of screening should be maternal history, where the risk reduction for preeclampsia is 10%. They are so very wrong. These big dinosaurs of the American College of Obstetricians and Gynecologists and the dinosaurs in the Society of Maternal Fetal Medicine in the United States. It's so wrong. The aspirin dose should be more than 100. The onset of therapy should be less than 16 weeks. The method of screening should not be maternal history. It should be history, mean arterial pressure, placental growth factor, and uterine perceivability index. And the reduction in the risk of preeclampsia is not 10%, is 90%. For preeclampsia before 32 weeks, is 75% for preeclampsia before 37 weeks. So, we have a lot of dinosaurs around. The dinosaurs will be forced to run away and they will become extinct, unfortunately, by women that demand that new methods of prediction and prevention should be introduced into clinical practice for the benefit of the pregnant women. So my hope is not the important, self-proclaimed important professional bodies, but it is the women that demand better care for themselves. Thank you.